Hello and welcome. Let's just dive right in, shall we? Today, we are undertaking a highly rigorous, incredibly detailed clinical explainer on a topic that truly represents the absolute frontier of modern transplant surgery. I'm talking about simultaneous heart-liver transplantation. For our audience today, and I know we have brilliant cardiologists, cardiothoracic, and liver transplant surgeons, and of course our indispensable anesthetists joining us, this session is really designed to dissect the profound hemodynamic, surgical, and immunologic intricacies of this dual-organ procedure. We are looking at a surgery that pushes the very boundaries of our clinical capabilities, requiring immense coordination and deep physiologic understanding. It's a fascinating, complex area, and I'm absolutely thrilled to explore it with you all.
Hello, doctors and clinical researchers. Thank you for your dedication to heart and liver transplant surgeries, anesthesia, and postoperative care. Today, we will learn about simultaneous liver and heart transplantation. Hallo liebe Ärzte und klinische Forscher. Vielen Dank für Ihr Engagement in den Bereichen Herz- und Lebertransplantation, Anästhesie und postoperative Betreuung. Heute beschäftigen wir uns mit der simultanen Leber- und Herztransplantation. And with that said, let's get into the incredible science behind this procedure.
Very quickly, here is our roadmap for this session. We'll start with an overview and look at how patient selection has evolved. Then, we'll move into the critical preoperative evaluation, followed by the intense anesthetic and surgical management required in theater. We will then tackle the rather thorny ethical and clinical debate between simultaneous and sequential allocation strategies, before diving into the hard data on post-transplant survival. Finally, we'll wrap up with the absolutely fascinating concept of immunoprotection and where the future is taking us.
Section 1. Overview and Patient Selection.
To truly appreciate where we are today, we have to look back at the historical milestones. It's quite staggering to think that back in 1984, just over 2 decades after the first successful isolated liver transplant, Thomas Starzl achieved something monumental. He performed the world's first combined heart-liver transplantation on a pediatric patient. It was audacious, and it completely changed what we believed was surgically survivable. Following that breakthrough, if we look at the data between 1987 and 2010, the primary driver for this dual procedure was actually familial amyloid polyneuropathy, or FAP. FAP accounted for over a quarter of all combined cases during that era, but the techniques were constantly evolving across the globe. Fast forward to 2011, and we saw a major milestone in Asia. A surgical team in Singapore successfully performed a combined transplant on a 57-year-old man with FAP. What's brilliant about this specific case is the sheer adaptability of the anesthetic and surgical teams. The moment general anesthesia induced massive vasodilation, the anesthesiologists were ready, immediately commencing a noradrenaline infusion to stabilize the hemodynamics. Even more crucially, during the liver transplant phase, the team strategically extended cardiopulmonary bypass of partial flow. Why? To protect the newly implanted vulnerable cardiac graft from the massive insults of hepatic reperfusion. It was a masterclass in physiological management. Today, despite the immense technical and logistical complexities involved, global volumes have steadily crept up to around 25 cases per year. It remains an ultra-rare, elite procedure, but it is one that offers immense hope for a very specific subset of patients.
So who exactly are these patients? Understanding the clinical shift in patient selection is absolutely vital. Historically, as we just mentioned, FAP with its associated cardiac cirrhosis was the dominant indication. But today we are witnessing a massive, undeniable paradigm shift. The growing population driving this procedure now consists of adult survivors with congenital heart disease, specifically those who are palliated in childhood with a Fontan procedure. Now let's pause and think about the physiology here. In the failing Fontan circulation, you have chronically elevated central venous pressure. Because there's no subpulmonary ventricle, that high CVP is transmitted directly and relentlessly back into the hepatic sinusoids. Over years and decades, this causes chronic hepatic congestion, which leads to bridging fibrosis and ultimately Fontan-associated liver disease, or FALD. The liver essentially hardens and fails due to the sheer backward pressure from the failing heart circulation. This is why we are seeing such an expansion in combined transplant indications for this specific group. Beyond Fontan patients, we are also carefully evaluating patients presenting with profound restrictive cardiomyopathy, hemochromatosis, and severe alcoholic cardiomyopathy, where both organ systems have been irreversibly damaged. And as our multidisciplinary teams become more skilled, we are successfully managing incredibly complex edge cases. Take, for example, a remarkable 2018 case out of UCLA. The team performed this dual procedure on a patient who had a congenital single kidney. You can imagine the immense risk of nephrotoxicity. Unsurprisingly, the patient developed profound postoperative acute kidney injury and required dialysis, but through meticulous postoperative care, they eventually achieved complete renal recovery. It just goes to show how far the boundaries can be pushed when the right expertise is in the room.
Section 2.
Preoperative evaluation.
For our cardiologist and pre-transplant screening teams, this is your operational matrix. Assessing heart function in any candidate presenting primarily with liver disease is absolutely paramount, and the clinical algorithms we use have to be incredibly rigorous. We routinely start with an ECG and comprehensive echocardiography. But I want to draw your attention to a critical threshold on this algorithm. If the echocardiogram estimates a right ventricular systolic pressure, or RSVP, exceeding 50 millimeters of mercury, we must mandate an invasive right heart catheterization. There is simply no room for guesswork here. We have to definitively characterize the pulmonary pressures. What are we looking for? Primarily, we are actively screening for severe portopulmonary hypertension. Let me be perfectly clear. Severe portopulmonary hypertension remains a strict contraindication for liver transplantation unless aggressive vasodilation therapy yields a profound, documented hemodynamic response. If you put a new liver into a patient with fixed, severe portopulmonary hypertension, the right heart will simply fail upon reperfusion. Furthermore, we must meticulously assess for cirrhotic cardiomyopathy. These patients often present subtly. You might just see QT interval prolongation on their baseline ECG. Because the overt symptoms of heart failure are notoriously difficult to distinguish from standard cirrhotic manifestations like fatigue or fluid overload, relying purely on clinical signs is a trap. You need this objective, invasive hemodynamic assessment before you even consider putting a patient on the waitlist.
Section 3. Anesthesia and surgical management.
Anesthetists, this part is for you. The intense hemodynamic monitoring setup required during both the cardiac and hepatic phases of this procedure cannot be overstated. You are managing two completely different physiological crises back to back. You absolutely must involve at least two highly specialized teams, a cardiac anesthetist who is profoundly proficient in transesophageal echocardiography, or TEE, and a liver transplant anesthetist who is an expert in managing the chaotic metabolic swings of the anapatic phase. Let's talk about monitoring. Continuous TE is non-negotiable. It is your eyes inside the chest. It provides critical real-time data on the new cardiac graft's function, continuous feedback on right ventricular filling, and crucial surveillance during the massive, sudden fluid shifts that occur during hepatic reperfusion. Simultaneously, central venous pressure monitoring is equally critical. This is especially true when you are managing a failing Fontan patient during the pre-bypass period. Remember, in Fontan physiology, there is no right ventricle pumping blood to the lungs. CVP is the primary determinant of pulmonary circulation. If you drop the CVP too low, cardiac output plummets. If it's too high, you worsen the hepatic congestion. It is an incredibly delicate balancing act.
Let's delve deeper into the specific intraoperative protocols. Induction itself is perilous. We strongly advise a rapid sequence induction. Why? Because these patients, particularly those with advanced FALD or cirrhosis, often present with massive ascites, significantly delayed gastric emptying, and a terrifyingly high risk of gastrointestinal bleeding or aspiration. Once you are on cardiopulmonary bypass, and remember, these bypass runs are going to be significantly prolonged, strict lung protective ventilation strategies are essential. You must utilize low tidal volumes and maintain a high PEEP. We are trying to mitigate the severe risk of postoperative acute respiratory distress syndrome, which is a major driver of mortality in these extended procedures. As the surgical team moves into the anaphylactic phase, the anesthesia team must anticipate and aggressively manage severe lactic acidosis. The lack of hepatic clearance combined with restrictive tissue perfusion creates a perfect metabolic storm. Furthermore, coagulopathy is a constant looming threat. The liver's out, the clotting factors are gone, and the patient has been on bypass. Blind, massive transfusion protocols based on standard lab tests simply take too long and are too blunt a tool here. Visa-elastic testing, specifically V-Day-driven transfusion strategies using ROTAM or TEG, are increasingly the absolute standard of care. You need real-time, precise data to guide your hemostatic resuscitation, giving exactly the blood products the patient needs at that exact moment.
Now, addressing our transplant surgeons, the major strategic debate in theater often centers on the approach. Do we perform the transplant sequentially or in block? Currently, the sequential heart-first approach is the accepted standard across most centers. The rationale is purely ischemic. The donor heart has a significantly lower tolerance for cold ischemia compared to the robust donor liver. So we implant the heart first, get it beating, and get the patient off bypass. However, the critical danger comes next. When you implant the liver and open the portal vein and hepatic artery, you get a massive reperfusion flush. This flush is cold, it is profoundly acidotic, and it is loaded with potassium. Hitting a freshly implanted, highly vulnerable cardiac graft with that chemical insult can trigger catastrophic arrhythmias or acute right heart failure. To prevent this, many experienced surgical teams strategically choose to extend cardiopulmonary bypass, or at least partial bypass, during the liver phase. This acts as a mechanical shield, supporting the new heart through the shock of hepatic reperfusion. Conversely, the en bloc technique is gaining serious traction. This is where the donor heart and liver are procured and transplanted together, still connected by the native inferior vena cava. The advantages are beautifully elegant from a physiological standpoint. It offers significantly shorter overall operative times and drastically reduces cold ischemia for both organs. Importantly, it allows for simultaneous reperfusion, completely avoiding that isolated hemodynamic stress on the new heart. However, let's be realistic. It demands incredibly complex and delicate donor procurement and a highly orchestrated team in the recipient theater. Both strategies have their merits, and the choice often comes down to institutional experience.
Section 4. Simultaneous versus sequential allocation strategies. Stepping outside the operating theater for a moment, we must impartially examine the profound ethical tension inherent in multi-organ allocation. When organs are so incredibly scarce, how do we fairly distribute them? The dilemma boils down to a classic ethical clash: justice versus utility. On the side of justice, critics make a very valid point. They argue that allowing a patient who is listed primarily for a heart to automatically pull a liver allograft out of the national pool unfairly disadvantages the thousands of single-organ waitlist candidates. It essentially allows one patient to jump the queue. On the flip side, we have the argument for utility. The data clearly demonstrates that candidates suffering from dual organ failure have a significantly higher waitlist mortality risk. They are the sickest of the sick. Providing simultaneous organs achieves the greatest aggregate good, or utility, by rescuing a patient who would otherwise almost certainly perish. This tension naturally leads to intense debates over whether a liver after heart or sequential allocation strategy, where the patient gets a heart first and waits for a liver later, could resolve this ethical conflict. But here is the stark, unvarnished reality of that sequential strategy, distilled into one single number: 302 days. According to robust analysis of the UNOS database, for patients who underwent an initial isolated heart transplant with the strict intention of receiving a sequential liver transplant at a later date, the median wait time between those two surgeries was an agonizing 302 days, over 10 months. The critical takeaway here is a massive survivorship bias in the data. A shockingly high fraction of patients who undergo the initial heart transplant simply fail to survive long enough to ever receive their subsequent liver allograft. The failing native liver ultimately drags the new donor heart down with it. So while sequential allocation might seem fairer on paper, in clinical reality it exposes the patient to an extreme risk of mortality between procedures.
Section 5. Post-transplant survival. So does the combined procedure actually work long-term? The answer is a resounding yes. A definitive, long-term survival advantage is clearly mapped out when we look at the OPTN and UNOS registry's Kaplan-Meier survival curves. Let's break down the 10-year survival data across an analysis of 236 patients. For those who successfully managed to receive a liver after heart sequentially, their 10-year survival is 53.6%. For those receiving a simultaneous heart-liver transplant, it is statistically equivalent at 52.1%. But here is the critical comparison. For those dual failure candidates who only ever received an isolated orthotopic heart transplant, their 10-year survival completely plummets to just 27.5%. To add even broader context to this, consider the 2025 Holmvard Systematic Review and Meta-Analysis. This study specifically compared combined heart-liver transplants to isolated heart transplants in the very challenging Fontan patient population. The combined approach showed a mortality rate of 0.03 per patient year, compared to a much higher 0.09 for isolated heart transplants. If you look at one-year mortality, it's 0.09 for the combined versus 0.14 for the isolated. Now, it is true that statistical significance drops slightly if we exclude older, pre-2000 data, but the overall trend is absolutely undeniable. If a patient has profound, irreversible liver disease at the time of heart failure, addressing the liver simultaneously is vital for long-term survival.
When we zoom in and look at highly specialized single-center cohorts, the outcomes are truly exceptional, though they come with caveats. A fantastic 2024 study by Vaikunth analyzed a 40-patient cohort composed entirely of failing Fontan patients, arguably the most complex group we treat. Their team achieved a 30-day survival of 90%, a 1-year survival of 80%, and a remarkable 5-year and 10-year survival both holding strong at 73%. However, we must remain utterly sober about the perioperative morbidity. This same cohort experienced a 60% composite comorbidity rate. This means 60% of these patients required intense interventions like post-operative mechanical circulatory support, renal replacement therapy, or a tracheostomy. It is a grueling recovery. Notably, the study found that a cardiopulmonary bypass time exceeding 283 minutes was strongly and directly correlated with increased mortality. Time is absolutely of the essence. In another fascinating series out of Bologna, published by Cardiothoracic in 2015, they looked at 15 combined cases. They achieved staggering 1-year, 5-year, and 10-year survival rates of 93%, 93%, and 82% respectively, alongside excellent freedom from graft rejection. But what is truly spectacular about the Bologna data is their use of the domino liver technique in 8 of these patients. They took the explanted native liver from a FAP recipient, a liver which is structurally perfectly sound, it just lacks a specific enzyme, and successfully transplanted it into another patient on the waitlist. This is a brilliant, highly innovative way of maximizing the utility of a painfully scarce donor pool.
Section 6. Immunoprotection and Future Directions.
Now let's talk about one of the most fascinating biological phenomena we see in these combined cases. On a microscopic level, we are witnessing a phenomenon known as liver tolerogenicity. When you transplant these organs simultaneously, the massive hepatic allograft doesn't just sit there. It actively acts as a profound immunologic shield for the new heart. How does it do this? The liver secretes soluble histocompatibility factors, and its sheer mass of Kupffer cells acts like an immunological sponge, actively clearing circulating donor-specific antibodies from the recipient's bloodstream before they can attack the heart. The clinical results of this tolerogenicity are striking. Extensive UNOS data shows that simultaneous recipients have remarkably lower rates of acute cellular rejection in their cardiac grafts compared to isolated heart recipients. Furthermore, there is a significantly noted reduction in the development of cardiac allograft vasculopathy, or CAV, which is traditionally a major long-term threat to heart transplants. Because of this powerful immunoprotection provided by the liver, our post-transplant teams are often able to run these complex patients on surprisingly lower, organ-sparing immunosuppression protocols. The liver literally protects the heart.
However, conversely, we must always keep in mind exactly how aggressively liver disease attacks the native heart prior to transplant. As clearly outlined in the seminal Repol 2011 review, liver cirrhosis intrinsically inflicts severe, often hidden, cardiac comorbidities. In end-stage liver patients, we routinely see the development of alcoholic and non-ischemic cardiomyopathies. We see the incredibly dangerous onset of portopulmonary hypertension, we see hemochromatosis-related cardiac iron deposition, and perhaps most insidiously, we see the development of cirrhotic cardiomyopathy, where the heart is hyperdynamic at rest but completely fails to mount an appropriate response to physiological stress. This review perfectly reinforces exactly why performing an isolated liver transplantation in these dual failure patients carries such an unacceptably high risk of sudden perioperative cardiac failure. It is also exactly why our pre-transplant hemodynamic evaluations must be utterly exhaustive. It's a dual-edged sword. The healthy donor liver protects the new donor heart postoperatively, but the failing native liver will absolutely destroy the native heart preoperatively.
Which leaves us with a final, rather provocative thought to conclude our masterclass today. As the population of adult congenital heart disease survivors continues to swell, the demand for combined heart-liver transplantation is undoubtedly going to rise significantly. So how will we, the specialists and clinical leaders in this virtual room, respond? How will we work together to develop equitable, multi-center allocation protocols and strict consensus criteria for these complex liver-heart candidates? How will we standardize our preoperative liver assessments and codify our intraoperative anesthetic guidelines to ensure that this life-saving, incredibly challenging procedure is delivered safely, effectively, and fairly to those who need it most? I challenge all of you listening today to lead the research, publish the data, and drive the clinical innovations that will define the next decade of this incredible procedure. Thank you so much for your time today, for your deep expertise, and for your relentless dedication to the art and science of transplantation. Take care.